I've given some CMC arthritis talks in the past, and feel like you can spend 2 hours talking about, whether you do an LRTI or fascial interposition or tightrope or whatever your procedure of choice is. But actually, this is such a common condition, and a lot of patients don't end up needing surgery. So we'll focus on some of the non-operative ways that we treat thumb arthritis. Alex, I'll call you on you a little bit if you don't mind. Yeah. So I don't have any conflict of interest with this talk. I will say though, thumb CMC arthroplasty is one of my favorite operations. So this is something that I enjoy doing, and it's one of the most successful procedures that we have available in orthopedics. So you can go from here to there pretty reliably with this surgery, but obviously not everyone needs the surgery. So we'll talk about some of the non-operative options today. And we've got Mary Margaret here. We've got orthopedic resident, a bunch of hand surgeons. So hopefully we can have a good discussion here about some of the options and what other people like to do as well. So we know how common this is. The way the thumb works, it's the opposition function that we have, makes our hands unique in the world. And in the animal kingdom, there are only a couple animals that can oppose their thumbs. So that's what makes us special. And so it wears out over the course of a lifetime, all that wear and tear that we get. And so it makes it difficult to open jars. We have decreased grip and pinch strength as a result, deformity, pain, reduced quality of life. And approximately 7% of men and 15% of women have a symptomatic thumb arthritis. So very common, obviously. We all know about the Eaton-Littler classification, starting from stage 1 to stage 4. Stage 1 radiographs are normal, or the joint space is a little bit wide if there's synovitis. And then stage 2 and 3 have progressive levels of osteophyte formation, joint space narrowing, subluxation, etc. And then stage 4, we see pantrapezial arthrosis. This classification does have its critics because it doesn't correlate with symptom severity. So you'll see a lot of patients with advanced x-rays, but they have minimal symptoms. And on the flip side, you'll see patients with severe symptoms and they have minimal x-ray findings. So again, what we say in orthopedics is treat the patient, not the x-ray. So I actually stopped documenting the Eaton-Littler classification. I think when I first started, I would use it, but it didn't really change my recommendations for patients, so I really don't even comment on it. I'm surprised that patients come in, they ask, they want, how bad are my x-rays, doc? What stage am I in, this and that. I try to redirect them and say, you have arthritis, we know that, but the x-ray severity doesn't dictate how we treat this. It's based on your symptoms and your quality of life, your function. So the patients kind of get fixated on this, what their x-rays look like sometimes. Because you'll see these people come in, this guy had carpal tunnel syndrome, and that's what needed to be treated. And his thumbs were obviously arthritic. He's got that collapse deformity, the shoulder sign, MP hyperextension. Thumbs didn't hurt at all. They just looked different. They worked fine for him. He just needed carpal tunnel releases. So, it begs the question. So Alex, what do you think, how common is asymptomatic thumb arthritis in the general population? Previous slide said that symptomatic is somewhere between 7 and maybe 15%. How many people are walking around out there with arthritis and they don't know? 30. Okay. If you were to do a study to determine that, how would you figure that out, do you think? What would you have to do to get that?
Just like an epidemiologic study.
Yeah.
You could look at radiographs involving the hand, but not for the thumb.
Right, exactly.
CMC.
So they've done that for knee, and they've done it for shoulder. They get MRIs of people who are asymptomatic, and they see what kind of pathology. And it's every decade that goes up, you're going to see more radiographic evidence. So this study has been done. So this is a patient you'll see who falls they injured their wrist. They obviously have distal radius fracture. That's not too bad, but you'll see their thumb is obviously arthritic. And this patient may or may not have any pain related to their thumb. So that type of patient prompted this article here. I don't know if you guys have seen this. This is a classic David Rings article from Boston. It's a play on the old Benjamin Franklin, everything in life, or nothing in life is guaranteed except death and taxes. You can add thumb arthritis to that. So what he did, he took 2,300 patients who had a distal radius fracture over 10 years and analyzed all those x-rays and saw how many of those patients had incidental degenerative changes at the thumb CMC point. In the 50s, there's about a 50% incidence. When you get up into the patients in their 90s, women had 100% radiographic arthrosis there. There weren't that many men in the cohort. 90-year-old men breaking their wrist was not a very common demographic, so that skewed the data, but you can see each decade it goes up. It's super common. What the study did, it didn't answer how many of these patients had symptoms, it just showed how many patients there were walking around with this arthrosis. So keep that in mind when we talk about treatment options for these folks. So I don't have any conflict of interest. This is the splint we use called MedSpec. It's a adjustable neoprene splint. It comes in different sizes, not very expensive. This is the Push MetaGrip, which comes in different sizes as well and is more expensive, but some patients like it because it's a lower profile. You can fit it under a glove. You can get it wet. And then this is the thermoplast splint, an option that a custom-made splint made by a hand therapist or occupational therapist. We'll talk about some of these here. So the evidence, sometimes patients are skeptical about the splint. Is it going to work? Do I have to wear it all the time? These kind of questions sometimes come up, but many studies show that they improve pain scores. And some studies show that they improve pinch strength and dash scores if you've used the splint for a few weeks. Which splint to use? There's conflicting results on that. These two studies up here show that the custom splints work better than the prefabricated splint in terms of pain scores and dash scores. And on the flip side, these three studies, patients preferred the neoprene splint over the custom splint for maybe comfort. So it's probably dealer's choice as to which one you want to use. Maybe there's some patient preferences there, but knowing that there's some options out there could be helpful. And sometimes I have a patient with two splints. They have a neoprene, they use it during the day, they sleep in a custom night splint. I've seen that work for some people.
John, have you seen any studies or recommendations about, because I've gone back and forth of, how much they should wear it? Roy Meals was our guest speaker last year at the Southeastern Hand Society meeting, and he's obviously done a lot of work in CMC arthroplasty.
Yeah.
He said he often had his patients wear it at night.
Right.
And he found that a lot of times really calmed down their symptoms. He's not exactly sure why.
Yeah.
Occasionally during the day, I guess there can be some, as we know, harmful side effects of over immobilizing something.
Right. So I think the protocols are all over the place. What I did see and what I've kind of done is tell someone to wear it every night when they sleep and then intermittently during the day, but not like 6 weeks, 24/7. I think I was trained, you're supposed to wear it all the time for like a month to get it to start working, but I usually do the night splint and then intermittently during the day, not 24/7. So, is that what you do as well?
I do the same thing. During the day, what I found, I tell them to try to wear it if there's an activity that brings on their symptoms.
Yeah.
I tell them to put it on, but what can happen is, especially with a rigid orthotic, when they're trying to do the activity, they're trying to do too much and it ends up hurting their hand. So I tell them, try to wear it, and if it's bothering you too much, take it off and wear it and put it on after the activity, but try to wear it during the activity.
Yes.
And that's the same thing with the neoprene, doing both. sometimes when they're doing activities during the day, the neoprene one, they don't cut into the hand as much as they're trying to do more. So they're more apt to wear that for those activities than the more rigid.
That makes sense, yeah.
And just so you know, we do have those check boxes in our form for you to check how you want them to wear it. So a lot of times they do the opposite, getting confused and check the box, you know, where it's needed for comfort, where it's night, where
Yeah.
full time for how many weeks.
So other things, this is more about therapy as well. So this is a study from Sweden. This study gets quoted a lot in some of these papers. It's amazing how things work in Europe. But so these 33 patients were determined to benefit from surgery based on hand surgeons who evaluated them. So they were put on a waiting list for surgery, and during that time where they're waiting for surgery, they went to therapy. And after 7 months, they're still waiting for surgery. And at that point, 70% of patients said that they didn't need surgery because their hand was better. And then after 7 years, they're still on the waiting list. And only 10% of patients requested surgery at that point. So their conclusion was that before going to surgery, you should have them try therapy, because a lot of patients get better while they're waiting for surgery. This is a similar type of study. This one is from the Netherlands. Larger group, 800 patients. They were treated with therapy, splinting. This was a 2-year follow-up. And over that 2-year period, 85% didn't undergo surgery. They had improvement in their pain scores and their Michigan Hand Questionnaire scores. And then one more study out of the Netherlands was similar, 170 patients. This was a 6-year follow-up study, and only about 20% of patients had surgery during that time. What I found interesting here is that most of the people who elected for surgery were the ones who didn't get better within the first year of treatment. So the people who got better during the first 12 months, that cohort had sustained relief over the next 5 to 6 years. So in other words, if you can get a patient's symptoms to calm down and get under control within that first year, chances are over the next 5, 6 years, their symptoms might be manageable and they may not elect for surgery. So it's kind of an interesting study.
One thing most of the studies don't have controls, right? So it's hard to tell, is it the therapy that's doing it, or is it just time? So you can't really make decisions on treatment on that, but definitely lets you know you don't need to just rush everybody to surgery. If they're willing to give it some time, maybe try some things.
That's right. They didn't have a control group. Yeah, that's right. Assistive tools therapies can teach them how to open jars with these. This is a program which I learned from one of these conferences, the dynamic stabilization program, and the therapists in our office use this program. Basically what you're doing is trying to open up the first web space and strengthen the first dorsal interosseous. You can see that rubber band exercise. So I'd forgotten about this, but the first dorsal interosseous takes its origin off the thumb metacarpal base. And so if you have radial subluxation of that joint, if you strengthen the first dorsal interosseous, you can reduce the joint and stabilize it. And there is Virginia O'Brien is a hand therapist who wrote this up, and she noticed some improvement in their pain scores and the quick dash scores with doing this program. And it's only like a 2-visit program. It's not like 5 days a week for months. So our therapists know how to do this. It's the Minnesota protocol, I think they call it, but simple to do. And I find it's helpful for the people in their 50s and 60s who want to do exercises and be active. And it seems to work well for those type of patients. I don't know, Mary Margaret, if you've had any experience with it. So Pam Tutton likes to do it too. I think she's talked about it. So,
What percentage of your patients do you refer to therapy for that? Is something discussion to give?
I started doing it more. I would say when I first started, I didn't think therapy was that helpful for that. But I think as some of these papers I've read, I'm probably referring more of them for it, like a higher percentage. And anecdotally, it seems to be working for some. So,
Are you gonna talk much about subluxation as it factors into pain and your treatment algorithm or not?
no, I really, I haven't, yeah.
Do you guys think like that's plays a factor? How do you explain it to patients when you're kind of describing what their x-ray shows? Because it is a common finding, and I think it does contribute to the pathophysiology of worsening arthritis. When your joint is 100% reduced, the force is transmitted evenly, whereas if you're 50% subluxated, you're going to be sort of loading that joint and have as much cartilage and more likely to wear it out over time. So,
I guess patient specific subluxation, but not real bad signs of arthritis yet.
Right. More subluxation. I just feel like I have a very cumbersome explanation now, and I feel like they're not understanding me. So I just wonder if anyone has a good, how they explain that finding, how important do they think it is? I forgot that they, that they actually feel like these strengthening exercises can help improve that. I'm slightly skeptical on that.
Yeah.
But, actually improving the x-ray, but it might improve the function, I believe.
Yeah, I don't think it improves x-ray changes, but it can make it less painful, which is the ultimate goal.
Especially those patients are often your younger females, right?
Mhm.
So you're not going to want to just jump straight to surgery on them.
Right.
So I think that's a great time where therapy can really be beneficial.
Mhm.
Try to change the dynamics across the joint.
Right. Yeah.
Yeah, I remember they did a study when you're at ASSH that showed that those ligaments that stabilize the thumb actually have estrogen receptors in them. So just like, your pelvic ligaments relax during pregnancy, you can actually probably stretch out your thumb CMC joint with those hormonal changes.
Right.
This is often a board's question, which ligament we're talking about, has a name.
The volar oblique.
Yeah, volar oblique, that's it.
Yeah, let's come back to that. Remember, it went to away from that for a while to the dorsal ligaments, but there was a study or paper I read recently that showed no, it's the anterior oblique ligament
That's the one, huh?
is the one again.
Full circle. 2 years from now, we'll be back to it.
It'll be back to that. Yeah, it'll change. The answer will change. Alex, about iontophoresis?
Not a ton, to be honest.
So it's a magical treatment that we have. You basically put this low voltage electrical current around an area, and you put a medication that has a charge to it. And with that battery hooked up, medication is drawn through the skin to the other side where the other voltage current is. And some of it does get into the blood vessels and the capillaries. If it's a superficial joint, it can get into the joint capsule to some degree. So it's kind of a short-term thing.
Do you have to put it like both on dorsal, or do you put one volar, one dorsal?
I don't remember, Margaret, where would you put it for a CMC? Do you ever use that, or
I
no?
don't use it for CMC.
Okay.
It's used because of usually it being in the joint.
Yeah.
It's like you said, it's pretty superficial.
Right.
Depending on how, talk about x-ray severity, I really feel like, with the placement to answer your question, the drug that's used with iontophoresis is dexamethasone.
Okay.
And that's a negatively charged drug.
Okay.
So they're on the electrode pad itself, there's a negative and a positive on the pad, and the drug being negative, you would put it on the negative, and that would go right over where the joint pain is. I asked them where the pain is.
Yeah.
And that's where I want the drug to be. It's transdermally delivered.
Uh-huh.
So, like you said, and the current draws the medication into the skin.
Right.
And on the positive, there's a saline solution that's applied.
Yeah.
And the patches that are out now, they typically wear them for about 24 hours.
Uh-huh.
And there's no benefit to wearing them any longer.
Okay.
It's just a single patch that's not hooked up to anything, right? It already has
Don't they
that.
charge it?
Yeah.
They charge it and then they can go home?
Exactly. There's a battery that we you pull on the battery and it activates the battery, and then they go home with the patch on. So there used to be the unit that had a hybrid circ that was responsible for delivering the medication, but now it's all
All
in
in
one.
one.
Yeah.
The battery's in the patch with one use, so that's nice. So they go home with the battery, so it's still delivering the current. Okay.
Yeah,
What I typically hear from patients, it helped them for like 5 to 7 days.
Right.
And then it was kind of gone, but at least during that time, a lot of patients request it when they come back. Hey, can I get that patch again today?
I agree, I've heard
You know.
that as well.
It's up to 6 treatments total, and it needs to be done like every other day or at least 2 times a week.
Oh,
If you go for too long in between, the medication dissipates. So it's in a time sensitive, delivery.
What's
Okay.
the depth of the delivery? Do you know that, because the topical medications, from what I understand, is like 5 millimeters for topical medications.
It's
Is I
pretty
took it similar.
So-
Yeah.
one article I read said that some of the effect is because it's getting into the capillaries in the kind of dermal and subdermal capillaries, so that can transmit it locally. I don't know if that's true or not, but, or if it's placebo, who knows, but,
I mean, it's more patient friendly than a needle stick, is what I.
Yeah. right. So I use this for someone who doesn't want an injection, maybe,
It would be nice to see a head-to-head between that and like Voltaren and gel, but to really see,
Right.
hey, is this more expensive delivery method, better, does it get deeper, does it help?
yeah,
See if you're looking for a research study.
there you go.
There you go.
And we often, in our office, seem to make a splint like this with the MP included. And that's particularly nice if the MP joint has some instability or there's some subluxation. This is Judy Coldit's splint where the MP is free. I don't know, I guess this one is less cumbersome to wear, but it doesn't capture that MP joint.
So they actually make splints now, non-thermoplast, that covers the MP joint as well. So that's what we use. So it comes all the way up to just pre-IP joints.
So a prefab splint, you got out of a box, okay. Pretty rigid like thermoplast or
It's
more
rigid.
small?
It's just not thermoplastic, it comes from here to here.
I got you.
Ah,
Do you know the company?
Rhizo, I think.
Oh, yeah.
Rhizo? Right.
Good thing is that I use it as a double as an MCT splint as well.
So for gatekeepers, okay.
Isn't Judy the one who also invented or designed the push?
Yes, the push metagrip, she designed that one. Yeah, so this is kind of like the push metagrip here, the custom one, so. It's, yeah. So, of course, we've got NSAIDs, we've got Tylenol. Tylenol, so one thing I learned putting this talk together is the FDA max dosage. So when I was in training, 4,000 milligrams was the max in a 24-hour period. In 2012, they changed that, and I guess I didn't read the alert, but they lowered it to 3,000 is kind of what the max dosage in a 24-hour period is. So,
I don't think Epic knows that.
does Epic know that?
No, it's not in the pharmacy.
Yeah.
Is that on our sheet?
It's on our sheet, 3,000.
changed.
We changed it. It was 4,000 and you pointed it out and I said, let me look into that. So yeah, it's 3,000 you can probably get away with 4,000, but from a legal standpoint, it's probably better to not recommend more than 3,000 in a 24
It was another way to try to reduce the opioid consumption, right?
Right,
Like that would make
Yeah,
a difference.
right.
For the combo drugs.
And they still don't know how Tylenol works. I tried to find the mechanism of action. They think maybe there's some COX inhibition in the brain and spinal cord, which doesn't occur in the peripheral tissues, but they still don't know how it works. It's kind of amazing. It's been around for 100 years. So we'll switch gears. This is topical stuff now. Voltaren gel is the brand name. It's a diclofenac 1% gel. And it used to be prescription only, pretty expensive, a lot of paperwork to get it approved. Now you can buy it. I think this is like $15 over the counter. So a lot of patients have already tried it. It's pretty cumbersome. So this one trial, 4 times per day for 8 weeks application. It's kind of greasy. Some people don't like using it 4 times a day, but you can get maybe 40% improvement in pain scores based on this trial. And there weren't that many adverse events like paresthesias or a rash. They didn't see anyone who had renal disease or, GI distress or bleeding issues with this. I know that is a theoretical concern is GI side effects like severe effects or bleeding, but in 800 patients, with this high dose, they didn't see any of that. So that's good to know.
Ron, I have a quick question about that. I have two groups of patients that I wanted to talk about with this. I think you kind of touched on it, but I give a handout for this on a lot of arthritic conditions, but particularly for thumb arthritis. I just had a guy today who has one kidney, and he's got a little bit of an elevated creatinine, and he asked me if it was safe, and I said that I think it is, but I'd recommend a deferral to your nephrologist. And also, I have a lot of pregnant patients who ask about it. I'm not aware of any contraindications for pregnancy, but I just wanted to see if you had read anything about either of those two conditions.
Yeah, I didn't specifically see that, like a one kidney person or pregnant patient, Tim. It's obviously a lot safer than a pill, but how safe is it? I don't know the answer on that.
Yeah, so I just defer to their specialist for approval, basically. But
yeah, I mean, on a case-by-case basis, that's reasonable for someone with a circumstance like that. Yeah,
Because certainly NSAIDs are contraindicated during pregnancy, right?
Yeah.
You're not supposed to take ibuprofen. So I just looked that up, Tim. According to the Voltaren's website, it says Voltaren is not recommended to be used during the first 2 trimesters of pregnancy. It shouldn't be used at all in the 3rd trimester.
okay.
But I'll say, if you go
that's
on the
amazing.
if you look at the package of Voltaren, there are so many contraindications.
Sure.
That's why it makes your head
No
spin.
other NSAIDs. It's not approved for the use of the shoulder. I think they just did a study for it. But
Right.
So I generally tell people it's safe. Don't have to worry about those. Pregnancy, that's a tough one.
That's a hard one. Yeah.
That's a big lawsuit.
You don't want that. You don't want that liability.
Yeah, and the interesting thing is when it has come up, because I do give this out, I give the handout out for this a lot. Every OBGYN says, go ahead and take it.
Okay.
Right.
That could be just the company protecting themselves.
Yeah, it could be.
Could be.
I guess the concern is there is a little systemic absorption of
Right.
and says
Yeah.
you want topical, but you got to be slathering a lot on.
Oh yeah. You have to be bathing in this stuff. I think.
Osteoarthritis is safe.
During
Ion
pregnancy.
because it's a steroid. It's Dex rather than NSAID, right?
That's good. That's good to know.
So I looked up CBD because patients are asking about this as well. And there was in Journal of Hand Surgery, there was a study looking at CBD versus a placebo shea butter. 18 patients. It was used twice a day for 2 weeks. And then it was blinded, randomized, and then they switched groups. And they, so the CBD group then did the shea butter. And so they noticed pain scores when people were taking CBD were better by 60%, and DASH scores were improved by 40% for thumb arthritis. Pretty significant for just this. So I wanted to know what is CBD and what is going on here. And so CBD is one of the components of the cannabis plant. THC is the psychoactive molecule, which obviously can get you high. But in hemp, hemp is classified as cannabis that has less than 0.3% THC. So it has CBD in it, but it has a lower amount of THC, so you're not going to get high on it. And so in North Carolina, it's legal because it's classified as hemp, as long as it doesn't have that much THC in it. Other states have different laws, but for now, that's kind of the way it's classified. Oral CBD is a different story. There's a lot of concerns about liver toxicity, infertility, drug interactions, and they're putting CBD in all kinds of stuff, food and vitamins, and that's not recommended because we don't know what the side effects are, what the effective dosages are. So I don't recommend any oral CBD if people ask. So Dr. Messer and I looked at glucosamine chondroitin a few years ago. We did a little in brief hand surgery review. The literature wasn't great on the evidence wasn't really high level on this topic. Most of the studies were sponsored by industry. The quality was variable. There were some mixed results, whether it was beneficial or not. And it took 2 to 3 months to see if these products were helpful for the patient. But we did find some studies that showed some promise, maybe some some positive results, and there were very few side effects. So at the time, we thought it's reasonable to consider this among other, non-surgical treatments. Nowadays, I don't recommend it as much because I feel like there's other things out there. I'll talk about turmeric. There's Voltaren gel. There's topical CBD. Also, when I would ask patients if they thought it was working for them, it was so hard for them to tell. So much happens in 2 to 3 months. Like the weather changes, or they're wearing their brace more, and so a lot of patients say, "I don't know if it's working, doc." So I don't really put a lot of stock in this stuff. So turmeric is something that I think is helpful for some people, for some patients. It's basically it's in the ginger root family, and curcumin is its active ingredient, and it's been shown to reduce COX-2 activity. So it kind of works like celecoxib, and it has a much better side effect profile. So there are some randomized controlled trials. This one here, this is 139 patients. Half took curcumin or turmeric, and half took prescription of diclofenac. And they had similar reduction in pain scores, and there were less side effects in the turmeric group. So I found that to be interesting, that this over-the-counter, basically root or spice, had the same effect as a diclofenac prescription.
Can we recommend that in people who are on the blood thinners, Coumadin and
I think
Eliquis?
Yeah, so it is a very mild blood thinner. It does not have as much blood thinning as the regular NSAIDs.
Mm-hmm.
I would say someone who's on a heavy duty one like Coumadin, probably not, but Plavix or people on aspirin, I have not discouraged that. So, but you're right, that is Coumadin would be a concern, because
I think it's also one of those supplements that certain surgeries they want you off of before you take it. Like if there's any like intracranial surgery or some sort of abdominal.
Yeah, it does have some blood thinning effect. Yeah. And then there's this whole nutraceutical market, which is like over $1 billion of these other supplements that have health benefit claims. And the FDA doesn't really regulate a lot of these. There's some variability in their quality. Some have contaminants. Some don't really have the active ingredient listed on the bottle. Patients want to know there is some third-party verification that can verify it for them. Like all these, omega-3 fish oil. I really don't have a lot of knowledge of whether these work scientifically. There's not that much data on them. I just kind of say, try it. If it works for you, great, but I don't really know how effective it is. So. Steroid injections, those are kind of the mainstay of treatment. I use them, when people are significant pain. I feel like they make a big difference. And the effect that we get is somewhere from 3 to 6 months of relief, just depending on which article you're reading. And the one I use is betamethasone or celestone. It causes less tissue atrophy. People who use triamcinolone say that it may work a little longer because it's insoluble, but you can get some tissue atrophy with Kenalog or triamcinolone. So something to keep in mind. Question is, does a cortisone injection damage articular cartilage? So Dr. Hauser's article gets quoted a lot, saying that articular cartilage is damaged by steroid injections. This is in the Journal of Prolotherapy, and he's the medical director of the where the world comes for prolotherapy. So he's looking at this topic from his lens, and when I kind of looked at how bad steroid shots are, this is a big review from 2015, and they looked at animal studies. It was kind of a systematic review. They looked at animal studies as well as chondrocytes in vitro. They put steroids in there, and then they put a catheter in like a rabbit's knee, and they flooded the knee with steroids. And so, as you would expect, high dose long-term steroids will damage chondrocytes. You know, if you put a catheter in a rabbit's knee and pump steroids in there for days, it's going to destroy the cartilage. But if you're using it sparingly at low dose, it doesn't seem to have that same detrimental effect. That was their conclusion. Additionally, here's another study looking at humans. They looked at steroid shots versus hyaluronic acid in knee arthritis. This was almost 1,000 patients, 7-year follow-up. And so everyone's knee did have some progression of osteoarthritis, as you would expect over 7 years, but it was a similar rate of progression. And the conversion to knee arthroplasty was lower in the steroid group. So my thoughts on steroid shots, first of all, if you're using them in a patient who already has arthritis, then this is kind of a moot point because their joint is already arthritic. And if you're using them sparingly, lower dose, then I don't think it's detrimental. I don't know, do you all feel similarly?
Yeah. I think there's probably a little truth to it. I'd probably try to steer away from like eating stage 1 and try other things first.
Okay.
Because I don't want to do anything that could cause it to progress.
Right.
But because I also feel like once they start down that road, you can get more surgery out of it because you know, it seems to me like they do you might have the one that you inject and they don't come back again and you assume that they've done well and it never bothers them again. But
right.
Most I see like the first one lasted for 6 months or a year.
Yeah.
Then they're back, you know, for a second one, which lasts for half the time. And then the third one, you're lucky, you know, as most of us know, you get a week or two out of it. So I feel like once I start the cortisone shots, I'm kind of putting them on a surgery track. So not always, but I'm maybe a little bit trying to get them to try some other things first.
Yeah. Yeah.
That's another study I'd like to see. I've never really seen that done well. Because I also see patients who maybe had injection by one of our partners 15 years ago in a thumb CMC joint.
Right.
Say, it's never hurt me, it's ever since. But
yeah.
So what is the rate of that? And so there's so many factors at play. It's hard to really tease it out. But right, obviously we're seeing the ones back that it keeps bothering them and everything. We're not seeing the ones back. It's
right.
Much that.
No, I do think there's definitely, that's what I mentioned. I do think there was that person, but I don't. It just gives me a little bit more pause before throwing it out right away. Like, this is gonna, cure, you know, I feel like, or someone comes in for a second opinion. On the flip side of that, I'm hearing on the radio, cortisone is toxic, it's poison, you know, these people that do stem cells and PRP that are charging $5,000 for an arthritic joint to do all these biologic treatments and saying that cortisone is basically malpractice.
Right, exactly. Yeah, you hear that.
I don't.
So I would disagree with those like promoters on radio. So do you have to get image guidance? So this was an interesting study about 60,000 patients. They did a big insurance database review. Some used a blind injection, some used ultrasound, some used fluoral guided. These were non-randomized, just basically up to the surgeon's choice. And so the timeline for a patient to request surgery or a repeat injection was not statistically significant among these 3 groups. So it didn't seem to give longer lasting relief. So, you know, kind of interesting. So there are dietary changes. I don't really talk about diet with anyone unless they ask about it, because I'm not a nutritionist, but some people say they ask, is my diet involved? And anyway, you guys know about the food pyramid. So back in the 70s, they recommended a bunch bread, cereal, pasta as 11 servings per day as kind of the foundation of the American diet, whereas, you know, fats and oils were kind of demonized. And so the food industry loved this. They made fat-free everything, snacks, which were high in carbs, high in sugar. And then the American Heart Association put their seal of approval on all these sugary cereals. So the American diet has traditionally been, high sugar, high processed food, maybe low fat too, but still not healthy. And that's turned out to be very pro-inflammatory. And so the rheumatoid arthritis patients, they can go on a plant-based diet, intermittent fasting diet, various diets, and some RA patients have noted improvement in their disease, which I find interesting, but it's inconclusive if OA patients get the same effect. A couple more slides. So lifestyle changes. I have seen anecdotally how patients who smoke often have more reported pain, and that's a real thing. So Mark Rizzo did show that smoking is associated with poor pain tolerance, higher pain, catastrophizing for whatever reason. And steroid shots don't work as well for smokers, and they end up undergoing surgery at a higher rate. But it's inconclusive if smoking cessation, weight loss, exercise, diet, it's not inconclusive if that helps hand arthritis. Mental health, I have to mention it. I really am not good with mental health assessments, but it is in our literature that depression correlates with hand disability and pain scores. So you've all seen that patient who's depressed, anxious, emotionally upset, and their pain is 10 out of 10. X-rays don't look so bad. It's hard to know which way to go with that person. And a lot of orthos are recommending mental health referrals or counseling, but I'm just not very good with that discussion, to be honest with you. So in summary, my practice for thumb arthritis, I recommend 4 to 6 months at least non-operative treatment, education, discuss the options, do a thumb, neoprene during sleep, intermittent during the day. I refer most people to hand therapy, especially if they're on the younger side and are active. I do steroid injections, maybe 2 to 3 max per year, but I don't think there's a number set in stone that says you can only have 3 in a lifetime. And when I was in residency, I looked up where that kind of unwritten rule came from, because you hear people say no more than 3 in a lifetime, that's it. And there's really no science behind that number.